Please note that this podcast is for informational purposes only and is not intended as personal medical advice. For that, please see your trusted healthcare provider. So today's topic, it's a hidden cause of heartburn in children and adults. Now, most of us have all experienced heartburn, or the medical term gastric reflux, at some point in our life. And usually it's associated with eating the wrong foods, spicy sauces, greasy foods, sometimes too much alcohol. Typically, it gets better when we reach out for those medications that lower the acidity, like over-the-counter Mylanta or Pepcid, or even Prilosec. However, when children and infants develop gastric reflux, and hopefully it's not from alcohol consumption, it's a bit alarming. And babies aren't supposed to have acid reflux. So it was really quite a discovery, I believe, back in the early 1990s, when gastroenterologists found that many of these infants and children with signs of gastric reflux had a condition that had really never been known before, called eosinophilic gastritis and eosinophilic esophagitis. Now, the GI doctors found on endoscopy cells that were lining the GI tract in these patients that had an abundance of a cell called an eosinophil on the biopsies. Now, eosinophils are typically associated with allergic inflammation and with allergic diseases like allergic rhinitis, asthma, and eczema. So what does this all mean? Was it a food allergy that's causing this inflammation in the esophagus and the stomach? And why was it causing symptoms such as heartburn and even choking? Well, my guest today, I'm super excited to have on, is Dr. Jonathan Spergel, who has been at the forefront of the research in this area of eosinophilic esophagitis and gastritis. He is the Stuart E. Starr Chair of Pediatrics, the Director of the Food Allergy Center, and Chief of the Allergy Section, all at Children's Hospital of Pennsylvania, which is better known among us colleagues as CHOP. It's known as the premier place for to take your children with complex medical conditions. So I'm super pleased to have Dr. Jonathan Spergel on the podcast.
Thank you. Thank you so much for hosting me. So I'm going to actually change one thing you just said.
Sure, go ahead.
Reflux in infants is seen in every single infant. So like 80 to 90% of infants have reflux, right?
Okay.
So reflux in an infant is normal. All babies spit up.
Okay.
Spitting up babies. That's
that's true. Right. My little ones. Yes.
So you just think about that. So babies spit up, and that's reflux.
That's an important point because, again, in setting the stage for that, again, that's why it could have been overlooked so easily that, again, it was just thought of as normal. Is that what you're trying to really say?
Yeah. So there was two things. So why it was overlooked for many years, it was for exactly what you said. It was over, and it's what often leads to the delay in diagnosis, is it's sort of normal when babies spit up.
Mm-hmm.
And so that reflux symptoms that you see in babies, that when it doesn't get better, because most infants outgrow reflux by 12 months, 18 months of age. But when it doesn't get better, or it doesn't get better with the medicines you mentioned, the over-the-counter Mylanta and Pepcid and omeprazole and all those sort of things, then you have to think about other reasons. What else is going on?
Mm-hmm.
To infants, you worry about lots of other things, right? They make sure it's nothing anatomical or something really funky, right?
Mm-hmm.
But when you ruled out those other things, then you think about eosinophilic esophagitis.
Well, let me interrupt for a second. So this is the key question I wanted to ask you. How was it originally discovered? Did a gastroenterologist, because it's a special stain when they have to look for eosinophils. I don't know if they routinely look at that. And
so it's a routine stain. So
it is. Okay.
Eosinophils have been noted in the esophagus probably back in the 70s, or the first case reports of it. I mean, it's just a normal H&E stain that you do when you look at the tissue. Is sort of a standard stain. It's not that uncommon when you look there. And
why did they?
It was discovered, the case reports that really brought it out was a case series done by Kevin Kelly and Hugh Sampson when they were both at Hopkins.
Oh.
And what they found out at that time, they had all these patients who had severe reflux, weren't getting better, even had gone surgical Nissen fundoplications, right? So they and they still weren't getting better. So they put them on an elemental diet, and they all got better. And then when they added foods back in, disease came back. And that sort of really proved that it was the case way back when, in 1990s. But there are a few other case reports in the adult literature from the earlier 80s of people with dysphagia. So that's one of the big things about
Yes.
EOE. The
Mhm.
symptoms change with age. So in the adults, it really is now the most common cause of food impaction. So in adults, we think about it as in food impactions and dysphagia or trouble swallowing.
That's a really important point. I think that one of the most dramatic things and that really does tip it off is when someone tells you they're choking on their food, because that,
Yes.
again, is not reflux. That's a whole other ballgame. And as we'll get into, that has to do with the inflammation and the pathophysiology that happens when, I guess, goes untreated. But let me ask you this again, just to go on one point. So you're saying they were routinely doing these things for eosinophils, but I guess there was a certain number they start to see. It was like greater than 15
Right, so
in the field when they look under the microscope.
So the number that you see, so normally in the esophagus, you see 0. That's the normal number. So if you look at a normal esophagus, it's totally 0.
Mm-hmm.
When they started to see more, the cutoff they came with, just to sort of say, hey, these people had a disease and this wasn't, because any inflammation, any reflux by itself can cause some esophageal eosinophilia.
Okay.
They came with the number of 15 eosinophils per high power field. It was just sort of a somewhat arbitrary cutoff that seemed to separate patients from one group to the other.
So they want enough of a barrier to say, oh, this is not just routine inflammation. This is
Correct.
something significant. It's funny also that you mentioned about the Hugh Sampson, putting them on the elemental diet. You're not going to remember this, but I have a vivid memory. I ran into you once at a conference, it must have been 20 years ago, and I think you were speaking about this. And I ran into you in one of the hallways at the conference, and I said to you, Dr. Spergel, what do we do about this eosinophilic esophagitis? And you said, just tell them to avoid the 4 or 5 major foods, and they'll be fine.
In a lot of ways, it's changed a little, but not a lot.
Well, we're going to get into the changes because I think they are important as well. But so what do you tell a parent that you've made a diagnosis now of eosinophilic esophagitis, meaning why the child is either having trouble swallowing, choking, or refluxing? What's your advice that you, in confirming the diagnosis and in their care?
So this is you being a good provider, is telling the families, look, hey, you have this disease of the esophagus, you have inflammation. Now we can understand why your child's having the symptoms. And then we say, look, hey, there are various ways of treating it, because we know for most, if not all patients, it is a non-classic food allergy. So not a food allergy that causes hives and anaphylaxis, but a food allergy that causes inflammation in the esophagus. And we go over the different ways of treating it. You can do it by medication or diet. Those are 2 different ways. And each one has its pluses and minuses. And you sort of go over what is best for the family and what do the families want. Because some families really want something simple. I want a medicine I can take and not really do my diet. And there's some patients who really want to do nothing with diet, nothing with medications at all, and want to let's take the root cause out.
How do you determine, and I know you know this, but I want to explain for the listeners, what's very tricky about this, as you know, is that a lot of these patients, the allergy testing, whether it's by skin or blood, is negative.
Correct.
Right? So is it through challenges? Like, how do you determine? Because, of course, that's the biggest issue with kids. As an expert in this area, like starting to take out wheat, taking out maybe milk or eggs, when we don't really know. Whereas when we know with a child that has really bad hives or, God forbid, anaphylaxis, we do testing and we have a pretty good idea they need to avoid that food. So how do you determine how they should start limiting, or do you have them just essentially limit all those key foods and slowly reintroduce?
So it's a great question. Excuse me.
Yes.
How can we tell the way that the way that you do standard testing, skin tests, blood tests, are great for telling for foods that cause IgE-mediated reactions. So those are reactions that cause hives, anaphylaxis. This is a non-IgA-mediated food allergy, so it does involve that molecule. So testing for that molecule, which is what skin testing and blood tests do, it's not going to show you anything. You may get positive results, but they're really probably not related to this disease. There's another test out in the market called IgG testing. IgG testing just tells me what you've been eating.
Right. That's a very important point, by the way, because I know you know about food allergies. Just for our listeners, because I see this all the time in my practice. Patients unfortunately spend $500. They get what is called that ALCAT test with IgG, and it shows they're positive to all these different foods, and they're distraught. And I tell them, this just tells me you're eating these foods. It doesn't tell you're allergic to these foods. So that I
Yeah.
just wanted to
So
point that out.
you are totally correct on that. It just tells me that, hey, you've eaten
Right.
X, Y, and Z, and which is not. So the way that you can tell right now, so is unfortunately trial and error, right? There is no, so basically what you have to do with this disease is you take the food out, and if your symptoms are gone, that's fantastic. Unfortunately, right now, we still have to do endoscopies with biopsies every time to watch progress, because symptoms don't always correlate with biopsy findings. You sort of need in this disease is both symptom improvement and biopsy improvement. So both. There is some examples. Hey, I've taken milk, egg, and wheat out. I'm completely better. And I've tried to add milk in, and he's throwing up again. I don't need a biopsy. I know milk is making me sick right now.
How long do you do that for? Like a 2-week trial?
So typically, you do about 2 months.
2 months. Will you have them eat the food every?
Symptoms probably will get better in 2 weeks.
Mm-hmm.
You could, but you probably just don't want to do biopsies that soon.
I wanted to ask you about that too, because obviously that's a big deal in kids too, putting them under anesthesia. What about, I was starting to read about and hear about this, the string test.
Right, so there are a few things, what we want to call about non-invasive tests to measure esophageal inflammation. So there's in terms of anesthesia, there's a few places that now do what we call transnasal. So which is you go down the nose and do the endoscopy. You can do that without anesthesia. So there's a few places.
That's better, but not so much fun either.
It's better, right? So we can get rid of the anesthesia. So the string test is where you basically swallow a string. You leave the string in for about an hour, then you pull it out. And it's a little unpleasant, but there's no anesthesia.
Right.
And then you can look on the string for the eosinophilic proteins.
Interesting.
But so it is an approved test, but right now it's not covered by any insurance companies that I know of.
Do you find it valid and useful in your following patients?
In a research standpoint, yes. Clinically, since it's not covered by insurance, we don't use it.
Well, I know it. I have another episode coming up about insurance. I just did an episode last week with a really good allergist, rheumatologist, and it was shocking for me to hear that sometimes patients have to go on methotrexate and other medications first before going, in some cases, to a biologic. We're going to talk about this with the EOE, because the insurance company won't pay for the newer medication unless you've been on the other medication. So I'm just curious about your opinion. If a patient says, look, I'm going to, for my child, I don't want him having an endoscopy, if we can monitor it with the string test, if you feel that would be adequate.
So I do think, so it depends. What you can't use the string test for the initial evaluation, but for some of the follow-ups that we have of when you're adding milk or taking things away, I think it will be very useful.
Yes. Do you think also too, I'm just going to throw this out. I know this is getting very technical for the listeners, but what's really interesting in our field, like this, what's called a CD markers, which in some cases is, again, I've read the literature and I've talked to some other experts, it can possibly replace food challenges. And you measure the CD3 marker for basophils, and this has to do with food allergies. Is there anything like that for eosinophils that you're aware of?
So is there a non-invasive blood test
Right.
that exists at the current time?
Mm-hmm.
The short answer is no. And there is nothing that people, I mean, there's been reports of stuff. People have looked at eosinophilic progenitor cells. There was a paper out of the Cincinnati group. It has, unfortunately, when I've seen the most recent abstract, it looked good on the first few patients, but when it's panned out, it hasn't. There is a test that we're developing that's looking at T cell function. So as we think this is more of a T cell epithelial disease, we're getting a little technical here, that is responsible for the disease. We think from a pathogenic standpoint, eosinophils are the end product. That this is disease of the epithelium triggering the T cells, or T cells triggering the epithelium, or the combination. But if we can find that you can get food-specific T cells that you can measure in the blood. We've seen this as well as the group down in North Carolina, and we can measure them in the blood, and that might be a way to look at it. It's in the process of being validated now. So they get a validated test. You need to do literally hundreds of patients. So we're about 2/3 to 3/4 of the way done.
Okay, well, that's promising.
So there will be a way to maybe identify the foods.
Okay.
Probably not going to replace the string test or the biopsy, or maybe another way to identify the foods, but that's still that's not commercially available.
Okay.
And doing it purely on research. So when we get patients' results, like results you have, like, I can't tell you, it's only research.
I know, but you'd be surprised, as you know, and I've been following your work for quite a while. Like, sometimes before you turn around, there's new diagnoses, there's new treatments.
Yeah.
Let me ask you something too, because two other really important areas related to this, and which is kind of surprising: inhalant allergies. Can that trigger the eosinophilic esophagitis? Because I think I've seen some reports about that. And is that important?
So good question. So for the vast majority of patients, it is a food allergy. A lot of patients can't figure out what food it is, and that's because they don't do the diet correctly or won't want to do the diet. But almost 90+% get better on a food allergy.
Okay.
A small percentage that is just pollen. So there's a few case reports of individual patients who have EOE purely only during pollen season. But it's in a few cases.
Okay.
Is a slightly larger percentage, but not significant, but it's non-zero, 10-ish%, maybe a little higher, that you'll see EOE, they have a food trigger, but their EOE triggers when their allergies are really bad. So you think about it, for EOE, you swallow a food and you trigger that inflammation in the esophagus that causes symptoms. During bad pollen season, you're probably either getting bad postnasal drip or swallowing enough pollen that you can get the same thing.
Okay.
So it's definitely been seen, is definitely seen in some of the sublingual pollen.
I'm going to get into that in a second too, even about foods. Let me ask you one other question before we get to that too. So would you say also too that it's rare to see eosinophilic esophagitis or gastritis also in a non-allergic patient? Because sometimes even I see adults that it's surprising. They have no history of allergies at all, and they've been diagnosed by the gastroenterologist with eosinophilic esophagitis. So is that also something in the young kids that you're not seeing the eczema, allergic rhinitis, and they still have it? Rare.
So it's in most patients with EOE have other atopic disease. It is probably most. It's probably like 80%.
Okay. Important. Okay.
So most patients with EOE have either asthma or allergic rhinitis, had a history of atopic dermatitis, have sort of anaphylaxis, right? So they have something else. So part of that general atopic picture, it's not all of them.
Okay, I think that's really important to clarify. Now, the really important question I want to ask you, and I'm sure a lot of my listeners are going to want to know about this, because I've actually done about 2 or 3 podcasts on food allergy treatment. I'm actually a little bit at the forefront. I've been doing sublingual allergy treatments with my patients for food allergies, similar to what Dr. Kim does, originally at Duke and now at North Carolina. But as you well know, because again, you've been very involved in this space, probably the more well-known food allergy treatment is oral allergy immunotherapy, or OIT. And while it has had some spectacular successes in helping to desensitize kids to peanuts and other foods, which is super impressive, there is a certain percentage of those patients that are developing, as you know, which, the problem. So what's your thoughts about that? Do you think that this could be a problem, in these patients?
So great question. And I don't think we have the final answer. There's a couple of interesting caveats. So general, when you do oral immunotherapy, and it works great in many patients, but there's a group that fail because they get really bad GI symptoms.
Right.
And most of the time when you stop the food, the GI symptoms go away and you're just done, right? How many of those patients with the bad GI symptoms have eosinophilic esophagitis, right? It's a little bit unknown, because in most people are like, hey, I stopped the food, why am I getting a biopsy? But when they've done the biopsy, many of them end up having EOE. So the rough estimate is anywhere from 5 to 10% of oral immunotherapy have EOE. So
Well, they also, as you know, can't stop the therapy. That's the desensitized. Then they have to continue to eat the food. And is that
right.
So sort of, I see what I think about, and that's why I like the sublingual drops better. It's like higher dose of the oral immunotherapy is like their body's own immune system. Their body really doesn't want those foods.
Right. So his question is, if you want to answer this, this is a multi-pronged answer here.
Okay. So we have the expert here.
So if you don't stop OIT, does EOE continue?
Right.
There's a case report out of the Arizona group where they saw transient EOE. I'm not sure how often that really exists, and I don't know if some of that transient was due to the fact they treated it with medicine. So it's to me, a little bit unclear. So some of it, in general, I think you're right. If you don't stop it, EOE is going to persist. So the question is it EOE just to the food that's causing it? So most of the time when you stop the food, so you're doing peanut and you get EOE to peanut, you stop the peanut oral immunotherapy, the EOE will go away. In these patients, I tend to think is the peanut was causing two diseases. It was causing anaphylaxis and EOE, right? So in those patients, they have to do what we call shared decision making. You can stay on peanut oral immunotherapy, but now I have to give you medicine for your eosinophilic esophagitis. And there's various medications.
But this is interesting. That gets complicated.
Right. But the other issue is can sublingual cause EOE? And I think
that was my next question for you. And I've seen very, very reports about that because we are giving a much lower dose. What I try to explain to patients when I sit down and talk to them, this beautiful work done by Edwin Kim and group that, in IT, the doses get up to several grams, whereas in sublingual immunotherapy, like the high dose, for example, in peanut is like 2 or 3 milligrams. So there's really magnitude of order difference of what you're getting. But anyway, I'm just curious because I'm sure
So the answer is, I think as you push the doses, so it depends where you go in your sublingual. I mean, if you start pushing, because most patients want to get on to a higher protective dose. And as you get to the higher protective dose, you're going to get it.
Interesting, because I think it's such a bigger difference. I fortunately have not really seen that. I mean, I've seen mouth itching and some other things, but nothing.
So as you push up to the patients just want to stay on a 10 to 20 to 30 milligram dose. They're probably less likely to get it. There's probably a dose response curve like we do in general. Anything we do, right? A bigger dose, you get more symptoms. So I think
what Edward Kim showed, I think in his work, that it was strange, but it went against our analogy, fighting off homeopathy. But he really, as you know, his papers in like 5 studies, he showed like about 70% of these patients, even at that 2 or 3 milligram dose, were able to tolerate up to 8 or 9 peanuts. Which again, what I tell my patients is, we're not looking to have you eat peanut butter sandwiches. Unfortunately, we just don't want, if you go into a restaurant and there's a peanut accidentally in your sauce, that you end up
So it is right. And then you look at the OIT literature where you put them up to 300 to 1,000. You're now going to tolerate like 24 peanuts, right? So there's a dose response curve.
Right.
I agree with you. Most of my patients don't want to eat that many peanuts.
Right.
But not true for milk and egg. They want to.
I don't blame them. You
the milk and egg, they really want to have that ice cream sundae.
Peanuts,
exactly. No one wants the peanut butter and jelly sandwich.
I'll move on to the last area, which is so important and where you've done groundbreaking work. As I said at the beginning of the podcast, I mean, got my Annals of Allergy journal, the top allergy journals, and your name is all over it. And, way on what's going on in the new exciting treatments. Also interesting, I know Evan Dillon at North Carolina has been doing, involved in that too. But would you do for the listeners, just explain the older treatments or maybe they're still current, for eosinophilic esophagitis, and the new ones that you just published, which I think are very groundbreaking.
So when we think about treating eosinophilic esophagitis, there are 2 therapies. We talked about diet, now medications. And medications tend to fall into 3 categories. There's proton pump inhibitors, which we use, which is the same medicines we started talking about at the beginning, treat reflux.
Right.
We have found that high dose proton pump inhibitors actually have an anti-eosinophilic effect. Very high dose, they block them out. They have some effect potentially on something called STAT6, which blocks allergic inflammation. So that's one way. So we tend to start with that. So if you get better with the over-the-counter medicine, you have pretty mild disease.
Oh, wait, are you
Then
calling this over-the-counter medicine? When you say over-the-counter medicine, what are you referring to? Like Mylantus?
omeprazole.
Well, okay, that's over-the-counter, but that used to be prescription, and it's still a pretty potent medication. But
Yeah,
okay,
but
right,
it's an over. It's
okay,
a proto.
right.
So Prilosec,
Nexium's
Nexium,
right. Got it.
all those.
Okay.
Start with that. Then if you fail that, then the choices traditionally was something called swallowed steroids. You basically
Right.
used to take asthma medicines poorly. So you had to take an asthma medicine in a slurry, or you swallow instead of
Right.
inhaling your into the lungs, you would swallow the propellant from the asthma medicines to coat the esophagus. And that worked reasonably well, but it was pretty inconvenient.
How would you do this with a young child? I'm just curious too. So let's say you have a 2 or 3-year-old. Would
So
you
when
do
the
it through a nebulizer, or would you
so
actually?
we would take the nebulized solution and mix it into a slurry and
You
swallow
say
it.
slurry like a drink?
Like a slurry, like a drink. So you would take like a teaspoon
Okay.
of syrup honey,
I get it.
you would mix it with the vial
Right, to try to, okay.
to do it. Then, obviously, that's all off label. That's
Mhm.
not sort of what you do.
Right. That's been an FDA approved.
It's not been FDA approved. It's in Europe. It's approved by the
Oh, okay.
EMA, so but not in the US.
I have a question too. How could that work? I'm just curious because in the esophagus is pretty rapid. Is it just by it flowing down there?
It's like the contact time. That's why you sort of have to into a thick slurry. The contact
that'd
is enough that you just like a train.
Mm,
It's always surprising. So it's one of the reasons why we tell patients that you take it, you don't eat or drink afterwards.
Oh, okay.
I let it sit there as much as
Mhm,
possible. You
mhm.
don't rinse your mouth out afterwards, which you do with like your inhalers.
Right.
We tell patients to take it before bed so it sits longer. We try.
Was there any issues? It's interesting between the high dose PPIs and the steroid stuff too of thrush with any of these
So
kids?
you get
Or
some thrush, not as so 5-ish% in the study, so 5-10% get thrush. Pretty easy to normal thrush. That's relatively easy to treat. It's not particularly resistant, but you definitely do see thrush.
okay.
So those was the ways treated. However, in May of this year, a molecule called Pilimab, but Dupixent, was approved for treatment of EOE for 12 and above. So this is a biological, so an antibody that blocks the IL-4 receptor alpha. And that molecule blocks the production, but that blocks the signaling, so the pathway of IL-4 and IL-13. And those are two key molecules for the production of allergy. I mean, it's just approved for eosinophilic esophagitis, but is it approved for many other atopic diseases? It's been approved for atopic dermatitis probably close to 5 years now.
Right.
Approved for asthma, nasal polyps, and and so
you feel it's pretty safe. I know I interviewed a doctor, as I said last week, Dr. Belistotsky in New York, who does with the biologics, just as part of her practice, and she felt it was pretty safe. I was shocked that you're allowed to self-administer at home.
Yeah.
So
I mean,
you're at anaphylaxis, like we did have to worry with Xolair.
Yeah, and I think the Zola anaphylaxis, honestly, we've been using Zola for 15 years. I think the rate of anaphylaxis is probably pretty minimal. I've never, I think a few case reports down in one spot, and I think honestly, it was some odd cross reactivity in a localized area of the U.S. because we really had. And I think one of the case reports was someone getting treated for idiopathic anaphylaxis. So it was
okay.
I have no concern. So when we think about biologics, and you'll see all the ads on TV.
Right.
So a lot of biologics, you really worry about off your immune system, and you're much worried about ability to fight infections. So you can't fight infections well. And some biologics affect your abilities rate to fight cancer. Right.
Because when people watch commercials, and I've always been aware of this, and I have friends of mine that are rheumatologists, they're always out with tuberculosis. They are worried about certain cancers like lymphomas with some of these biologics. I'm not sure if it's the tumor necrosis factor blockers, but you're saying with these, you're pretty confident.
Yeah, I'm not like the TNF blockers, the JAK inhibitors, which are the two other ones that you'll see a lot on.
Yeah.
They definitely have worries, right?
Okay.
I mean, these things that there's not those risks with dupilumab and omalizumab. I mean, there's with dupilumab because that blocks the T2 pathway so well. So when you think about it, for your listeners, the T2 pathway is what turns on allergies, and your body's supposed to have a balance between the T2 pathway and activation of the sort of balance against pathway. And the T1's the one that, if that's
Right.
dysregulated, you get diabetes, right? So you have this balance, and there's a
Right.
regulatory cell on top that's supposed to balance, keep everything on.
Right.
So people worry in theory that if you knock down T2, you're going to have more T1. It has not been seen yet, but people do worry. The drug's been around for 5 years, so maybe we'll see it at some point. I do think long as we're not messing with our T regulatory cells, we'll be okay. If we mess with T regulatory cells, then I start to worry. I mean, that's what some drugs work at, some of the more potent immunosuppressants.
Right.
That we worry about transplants and things like that, where you really need bigger guns. So at this point, I'm not too worried about those things, but that's the one potential worry that we would see at this point.
How long would you, let's say you diagnose a child with EOE, and I don't know, they've been eliminating some foods, but obviously they still, once in a while, I guess they're going to friends' parties, they're eating some of the foods, and you put them on Dupixent and you're controlling them. How long do you have a time factor? Like you say, okay, I'll do this for 6 months and then we'll take a break and see how they do. What's the clinical?
So it's a great question. I know. So my general thought is this is a chronic disease, like many other diseases which we treat in allergy, that it's unlikely to.
Okay.
But we don't know if this drug has the holy grail in allergies is disease modification. Can we change the disease process? Because what we've seen in this disease is a very small percentage of patients who outgrow it. So what we've been trying to do is go to the lowest dose that works, right? So if the drug now is prescribed weekly, right? So if
it's weekly. It was every 2 weeks. It's every week.
For EOE, it's weekly.
Every week, so they have to give the injection
once a week.
And you're having the parent do, or
the parents can do it. They can do it themselves. This is self-injecting needles. Depends.
So it's like an EpiPen type of thing. Okay.
Yeah. So they check in 3 or 4 months because you have to make sure the drug really works for them, right? So you do a biopsy, say it works. Your scope is normal. You have no symptoms.
Right.
Then we would say, hey, if you want, we can go every other week. Let's
spread it out.
Spread it out. You see how far we can spread it out. Once we sort of get the dose, we don't know what the right answer is. But from what we did in the past for like when we just swallowed steroids or PPIs, we left them on that dose for 2 years. And then we tried to wean them again. So we just wanted to get let's heal them, keep them well, not do anything. You're great. You're on week, you're doing well. Let's just leave you on that. We'll see you back in a year, renew your prescription a year after that. Let's see if we can stop you then. The drug's been only out since May, so I have no idea what this will work.
So it's early.
But that's what we tried for swallowed steroids. In a few patients, we were able to wean things, but most we could not. So this one, we don't know.
I see one other question too, because again, you're such an expert in food allergy. I know you trained at Mount Sinai, where Dr. Sampson was for many years. I don't know if he's still there. And
he's still there.
Yeah, okay, because I know Dr. Sickwood kind of took over a little bit.
Yeah.
Why do you think didn't become the holy grail for food allergy? Because blocking IgE. I know it was a patent dispute. That's why it kind of
so complicated answer. So some of it's the patent issue.
Okay.
So when they did the trial, oh my God, how long ago? It was a long time ago.
Yeah, it was like
there was a clinical trial. There was the original 10x clinical trial. And 10x was another pharmaceutical company that I can't remember. It was Genentech or Novo. One of them bought out. And when they were doing the clinical trial, they had too many severe reactions on the challenges. So the company stopped the trial.
Oh, gosh, yeah.
So right now, a clinical trial being led by Bob Wood down at Hopkins, something called Outmatch. And Outmatch is the use of Xolair as a preventative, something for allergic reactions for children with multiple food allergy.
Oh, wow.
So it makes
that's good.
And there's a phase 3 clinical trial, which hopefully will be done shortly. It has been moving very slowly due to it was during the pandemic, everything sort of stopped.
Yeah, sure.
Right. So, but that trial is, to my knowledge, almost done. It's moving along.
Just curious, because I was wondering in your experience if you'd have, because obviously Xolair is widely used now for moderate to severe asthma, and a lot of these times have food allergies. if we were seeing any protection. And I know also, as you're aware, that sometimes, even though it'd be very expensive, they were recommending for immunotherapy, whether it was subcutaneous or OIT,
Yeah,
sometimes
so
to have concomitant Xolair treatments to help,
right, so
you know.
so it's been so I've looked at it as an adjunct in oral immunotherapy. There's been probably a dozen studies, and it's been effective. So it can get people up to doses on oral immunotherapy faster.
Mhm.
I am highly optimistic. I've not seen any of the data. We're all blinded. I am highly optimistic that it's going to work, right?
Yeah.
Is it going to let people? So basically, what you'll have to do is you'll have to be on Xolair, and when you're on Xolair, you're protected to
Right. A lot of allergens.
to a lot of allergies, but not you won't be able to eat that peanut butter and jelly sandwich, but it gets cross contamination. So it'll be very for that, and it'll be theoretically useful for cross any food, but it's we haven't seen it yet, so we don't know.
Yeah. That's going to be very tough though, getting the insurance companies to pay for 2 immunotherapies, right? I mean, to give those pay for whether it's allergy injections or sublingual
Yeah.
drops or whatever,
I mean,
OIT.
so what I think, I mean, this is my thinking about how I would do this. Once say everything's approved, is like
Right.
you put Xolair
Right.
for 4 to 6 months,
Right.
you get them up there, and then you start them at a maintenance dose. You can skip all the buildup,
Oh,
put them
interesting.
on the maintenance
That's very
dose,
bold, but yeah, that's very interesting. Yeah, I like that
and you just leave them
thinking.
on the maintenance dose. Like, okay, you're
Yeah.
done.
But, you know, here's something.
Because that was in clinical trials. They basically did that,
Yeah.
and we just started everyone at 250 milligrams, and they all did fine.
You know, it's interesting though. This is one of the things also I explain to patients because I gave a lot of thought to this. See, what's so interesting about what we do, you know, and I trained at Luke Roosevelt, the original allergy, the Cook Clinic, the original place where immunotherapy started in the United States.
Yeah.
And what's really interesting, you know, even though it's an older therapy, I think that it's kind of like working out. It's about the process of starting low and building up, that the immune system goes through these, you know, iterations that eventually that immune tolerance, which, you know, but when you give maybe these new biologics, we skip the line, but I don't know. And I
Yeah,
wonder,
it's an question. Do you need
Yeah.
that gradual buildup? I
right.
don't think we know.
Yeah. All right. This has been an discussion. I feel so privileged to have this time speaking to you. Is there anything else you just would like anybody, the listeners to
No, I
know
would
about?
say I just want to reiterate what you said in the beginning. This is an evolving field, and talk to your providers because things change all the time.